Posterior thigh itself, and after doing the posterior thigh we are going to deal with the hip joint. So the major task today would be to start with the gluteal region, and then we will go into the posterior thigh, and then finally we are going to deal with the hip joint. So the objectives here would be, initially we will start with the bony landmarks of the posterior aspect of the hip bone and the femur. Then we are going to describe the origin, insertion and nerve supply of the gluteal muscles, and also some of the clinical aspects of the gluteal muscles. And then we are going to describe the origin, insertion, nerve supply of the hamstring muscles, or the muscles of the posterior compartment of the thigh. In between also, before we start the gluteal region, we would also deal with the sacral plexus. We dealt with the lumbar plexus in the previous session, but we will deal with the sacral plexus in this session, so that most of the nerves which are supplying the gluteal region and the posterior part of the thigh are originating from the sacral plexus. So we are going to deal with the sacral plexus and the nerves which are coming out from the sacral plexus as such also. Okay, so if we start to look at the bony features on the posterior aspect of the hip bone and the femur, we can see this prominent thing on the top of the iliac crest. This is the iliac crest, and then this is the tuberculum, which is called the tuberculum of the iliac crest. This tuberculum, from anterior superior iliac spine to the tuberculum, a muscle comes out from here which is called the tensor fascia lata. Then you can look at the ala, or the wing of the ilium, and you can also find out the anterior superior iliac spine, and this is the posterior superior iliac spine. This one is the anterior inferior iliac spine. And you know that from anterior superior iliac spine to the pubic tubercle there is a ligament which is called the inguinal ligament. And if we look at the back, you would find that there is a posterior superior iliac spine, and then you have a posterior inferior iliac spine. On the surface of the posterior surface of the ilium, it's also called as the gluteal surface. There are three lines, and these lines are called gluteal lines. So the first one which you are seeing here near the posterior part is called the posterior gluteal line. Then you have this line which is called the anterior gluteal line, and finally the third one is called the inferior gluteal line. So you have three gluteal lines. You have the posterior gluteal line, you have the anterior gluteal line, and you have the inferior gluteal line on the gluteal surface of the ilium. There is a pelvic surface of the ilium which gives rise to the iliacus muscle, but we are talking about the gluteal surface of the ilium, which has these three lines: the posterior gluteal line, anterior gluteal line, and then you have the inferior gluteal line. The gluteus medius muscle is going to originate between the posterior and anterior gluteal line, and gluteus minimus muscle is going to arise between the anterior and the inferior gluteal line. So that's why these gluteal lines are important in terms of the origin of the gluteal muscles. Next we are going to look at some other landmarks, like this is the acetabulum, and then you have this notch which is the greater sciatic notch. This is the ischial spine. The ligament from the sacrum to the tuberosity of the ischium is called the sacrotuberous ligament, and from sacrum to the spine of the ischium, this is called the sacrospinous ligament. This converges, these two ligaments converts these two notches which you have, the greater sciatic and the lesser sciatic notch, into a greater sciatic foramen and a lesser sciatic foramen. So you have a ligament which is coming from the sacrum going to the tuberosity of the ischium. It's called the sacrotuberous ligament. and then you have the sacrospinous ligament, which is coming from the sacrum going to the spine of the ischium. It converts the greatest sciatic notch into the greater sciatic foramen, and similarly the area between the sacrospinous ligament and sacrotuberous ligament becomes the lesser sciatic foramen. The greater sciatic foramen is important because the blood vessels and the nerves from the pelvis exit out from here and enter into the gluteal region. The lesser sciatic foramen is more important because vessels and nerves from the gluteal region will re-enter into the pelvis through the lesser sciatic foramen. So you need to understand two things. The greater sciatic foramen is important because the nerves and vessels within the pelvis are going to come out and go to the gluteal region through the greater sciatic foramen. While the lesser sciatic foramen is important because the nerves and vessels within the gluteal region will re-enter into the pelvis through the lesser sciatic foramen. So one example of the big nerve which comes out from the greater sciatic foramen is the sciatic nerve. And one example of a nerve which goes back into the pelvis through the lesser sciatic foramen is pudendal nerve. Okay, so you need to understand that greater sciatic foramen is more important because the nerve and vessels are exiting out from the pelvis, going into the gluteal region. Lesser sciatic foramen is important because there are nerve and vessels which are in the gluteal region going back into the perineum or pelvis, through the lesser sciatic foramen. Okay. So next we are going to talk about the superior pubic ramus here, and then we have the pubic symphysis. This is the inferior pubic ramus, and then you have the ischiopubic ramus, which is this one. This is the ischiopubic ramus. This is the ischium. This is the pubis. So this is the ischiopubic ramus. You have the ischial tuberosity, which is this area, and the ischial tuberosity is important when you are sitting. Why ischial tuberosity is important? Because usually the ischial tuberosity is covered by this muscle, which is the gluteus maximus muscle. But when you flex your hip and you sit down, the gluteus maximus goes up. So you are sitting on your ischial tuberosities. So when you flex your hip and sit down, your gluteus maximus goes up and you are sitting on your ischial tuberosity. So there is a bursa between the ischial tuberosity and the skin, which is the ischial bursa. Okay, so you are literally sitting on your ischial tuberosity. There is only a bursa between the skin and the ischial tuberosity when you are sitting down. When you are standing up, your ischial tuberosity you cannot feel because it is under the cover of gluteus maximus muscle. Okay. But if you try to, go deep on the medial aspect of the lower part of the gluteus maximus, you can feel your ischial tuberosities. But when you sit down, gluteus maximus goes up and you are sitting on your ischial tuberosities. This is the head of femur, neck of femur, greater trochanter, lesser trochanter, intertrochanteric crest. We have talked about the gluteal tuberosity before also, and linea aspera also. So these are some of the important bony landmarks related to the posterior aspect of the hip bone and the femur. Okay. Next we are going to talk about a little bit on the lumbar plexus, on the sacral plexus. The sacral plexus is going to be formed by the ventral rami and the dorsal divisions, ventral rami of L4, L5, S1, S2 and S3. So L4, L5, S1, S2 and S3 together, the ventral rami of them are going to give rise to the sacral plexus. Lumbar plexus, we said it was within the substance of, it was arising from T12 to L4, and it was within the substance of a muscle which we call psoas major muscle. Most of this sacral plexus will be lying on the muscle which is called the piriformis muscle. So piriformis muscle is inside, it is going to be inside the pelvis over the sacrum, and in that part the piriformis muscle is the is the muscle where the sacral plexus is going to be formed. It is joined by a branch from the lumbar plexus, L4 and L5. You see L4 and L5 are coming together and joining with S1 and S2 and S3 to give rise to the sacral plexus. So the lumbosacral trunk is the L4 and L5, which joins with S1, S2 and S3 to give rise to the sacral plexus. Now the biggest nerve which comes out from the sacral plexus is this nerve, which is the sciatic nerve. Sciatic nerve has two components. It has a common fibular component which is coming out from the dorsal divisions of these ventral rami, and the ventral division of these rami are going to give rise to the tibial component. So the two components of the sciatic nerve are the common fibular component, and the other one is the tibial component. Now the sciatic nerve does not supply any muscle in the gluteal region. It is passing below the piriformis muscle. It passes below the piriformis muscle, passes through the greater sciatic notch, comes into the gluteal region, and then goes over the back of the leg. But it does not supply any muscle in the gluteal region. It supplies the muscles in the posterior compartment of the thigh. The hamstring muscles are supplied by the sciatic nerve. Okay. Even its cutaneous supply would be in the leg and the foot. So it is not giving any cutaneous supply to the gluteal region. It is not supplying any muscle in the gluteal region. It is going to supply the posterior compartment of the thigh, the hamstring muscles, and then it is going to supply the muscles in the leg and the foot, and it is also give cutaneous supply in the leg and the foot, but it does not supply anything in the gluteal region. The second important nerve which you need to see here is the superior gluteal nerve. Can you see this one? It's coming from the dorsal division of the L4, L5 and S1, and it is going to be called as superior gluteal nerve. This is the only nerve which arises above the piriformis muscle. Piriformis muscle is exiting out from the greater sciatic notch. All the nerves of the gluteal region are going to arise below the piriformis muscle. The only nerve which comes above the piriformis muscle is the superior gluteal nerve. It is also going to exit out from the greater sciatic foramen, and it is going to supply the gluteus medius and minimus muscle. So superior gluteal nerve is important because it is supplying the gluteus medius and minimus muscle. It also supplies tensor fascia lata muscle. So gluteus medius, minimus and tensor fascia lata, these are the three muscles supplied by superior gluteal nerve. Then you have this nerve, which is the inferior gluteal nerve. It arises from L5, S1 and S2, and also the dorsal division of L5, S1 and S2. And this nerve exits below the piriformis muscle, and it supplies the gluteus maximus muscle. Then you are looking at these nerves, which are the nerve to obturator internus. The nerve to obturator internus is going to be coming out from the ventral division of the S1, S2 and S3, and this nerve is going to supply the obturator internus muscle. Then you have this one, which is the nerve to quadratus femoris and gemelli inferior, and this nerve is basically arising from S1, S2 and S3 and the ventral divisions of that, and it is going to supply the quadratus femoris muscle and the gemellus inferior muscle. Then you can see this nerve, which is arising from ventral as well as the dorsal division, and this one is called the posterior cutaneous nerve of thigh. This nerve runs over the top of the sciatic nerve. Although this is a cutaneous nerve, but it is not found in the superficial fascia. It runs over the top of the sciatic nerve, and near the upper part of the posterior aspect of thigh, it becomes cutaneous and then gives cutaneous supply to the back of the thigh. Then we see this nerve, which is the pudendal nerve. Pudendal nerve is important because this nerve basically exits out from the greater sciatic foramen, and then through the lesser sciatic foramen it goes back into the perineum, supplying the muscles in the pelvis and the perineum, and also it is also going to supply some of the organs within the pelvis and the perineum. So pudendal nerve you would read more when we are going to discuss pelvis and the perineum in the reproductive system. So again you can see these nerves. This is the lumbosacral, this is the sacral plexus. You see this muscle, this is the piriformis. So you can see it is lying over the top of the piriformis muscle. You can see the L4 and L5 are coming here, joining with S1 and S2 and S3 to give rise to this plexus, which is the sacral plexus. The big nerve which is exiting out from the greater sciatic foramen is the sciatic nerve. Then you can see the inferior gluteal nerve. Can you see this one? And the only nerve which is above the piriformis is the superior gluteal nerve. The rest of them you can see just passing below the piriformis, which includes the nerve to quadratus femoris, nerve to obturator internus, and then you can see the nerve which is the posterior cutaneous nerve of thigh, and then perforating cutaneous is also there. So these are the nerves which you see coming out from the sacral plexus. If we look at the function of these nerves, the first one is the sciatic nerve, and we said that sciatic nerves supply all the muscles of the hamstring compartment. So it is supplying all the muscles of the hamstring compartment. It is also supplying the muscles in the posterior part of the leg, especially the tibial component of it. It is going to supply also the posterior or the flexor compartment of the leg. So the posterior compartment of the leg is the flexor compartment of the leg. So the flexor compartment of the leg it is supplying the hamstring muscle. It is supplying the skin on the posterior lateral aspect of the sole of the foot, and it is also supplying the plantar surface of the sole of the foot. So this is the tibial component of the sciatic nerve. The fibular component of the sciatic nerve is going to supply one muscle here in the back of the thigh, which is there are two heads of the biceps femoris. So the short head of biceps femoris is supplied by the common fibular nerve, and all the muscles in the anterior compartment of the leg. Okay, so the anterior compartment is the extensor compartment of the leg, and they are all supplied by common fibular nerve. Common fibular nerve also supplies the skin over the lateral aspect and the anterior aspect of the leg. So the lateral and the anterior aspect of the leg and the dorsum of the foot is supplied by common fibular component of the sciatic nerve. Pudendal, as we said, is going to supply the muscles in the perineum. It is going to supply the skin over the external genitalia, anal canal. So that is the major function of pudendal, which we are going to discuss when we do the reproductive block. Superior gluteal, we have talked about that it supplies gluteus medius, minimus, and tensor fasciae lata. The inferior gluteal nerve supplies the gluteus maximus muscle. And if you look at the nerve to obturator and superior gemellus, it supplies the obturator internus muscle and gemellus superior muscle, while the nerve to quadratus femoris is going to supply the quadratus femoris muscle and gemellus inferior. We are going to talk about these muscles as we look into the gluteal region. Then posterior femoral cutaneous nerve is going to supply the cutaneous supply to the posterior aspect of the thigh. And then we have the nerve to piriformis supplying to the piriformis muscle. And then these are coccygeal plexus nerves, which we are not going to talk about today. We are only going to talk about the nerves which are from the sacral plexus, which include the sciatic. Sciatic has tibial and common fibular component. Then you have pudendal. We have talked about nerve to obturator internus, nerve to quadratus femoris. We have talked about the superior gluteal, inferior gluteal, and posterior cutaneous nerve of thigh. So these are the nerves which you need to know about the sacral plexus. This is the diagram showing you some of the cutaneous supply. We have already talked about the cutaneous supply in the front of the thigh. This is the cutaneous supply on the back of the thigh. So what you are seeing here, the upper part of the gluteal region is supplied by posterior rami of L1 and L3, while this lateral part is supplied by the posterior rami of S1 to S3. Most of the posterior part of the thigh is supplied by posterior cutaneous nerve of thigh, which is a branch of the sacral plexus. The medial side of the posterior part by the obturator, and the lateral part of the posterior part is by the lateral cutaneous nerve of thigh, which is a branch of the lumbar plexus. Okay, so this is some of the surface marking which you should be able to make out. You can draw a line at the highest point of the iliac crest. So you can actually find out your iliac crest and draw a line at the upper part of the iliac crest. And then you can find out this fold which is called the gluteal sulcus. This is the area which is called the gluteal region. So from the highest point of the iliac crest to the gluteal sulcus, this area is the gluteal region. Below this is the posterior compartment of the thigh, or the thigh. Okay. So on the back, if you make out the highest point of the iliac crest, and you can see this fold which is called the gluteal sulcus. Between this is the gluteal region. And this sulcus is mainly formed because of the lower end of the gluteus maximus muscle. Now if you look at the gluteus maximus is mainly arising behind the posterior gluteal line. So this is the posterior gluteal line. It is arising behind the posterior gluteal line. It is arising from most of the sacrotuberous ligament, and then it is going to get inserted into the gluteal tuberosity, and most of it is going to be inserted into iliotibial tract. So 2/3 of the gluteus maximus muscle is going to be inserted into the iliotibial tract. 1/3 of it is going to be inserted into the gluteal tuberosity and to the linea aspera. If you look at some of the areas, so this is the area where your ischial tuberosities are going to be, and so it is covering, the gluteus maximus is actually covering the ischial tuberosities also. So but once you sit down, the gluteus maximus moves up, and the ischial tuberosities are much more, you are sitting actually on the gluteal tuberosities. Okay, let's build up the gluteal region here. So we start with the piriformis muscle. The piriformis muscle is arising from the sacrum, from the middle three pieces of the sacrum. It passes through the greater sciatic foramen and gets inserted into the tip of the inner aspect of the greater trochanter. Okay, so this is the major function of the piriformis muscle would be lateral rotation, but it's a weak lateral rotator. So the attachment is important, but it does not have a very important function. The more important thing about the gluteus, about the piriformis, it's its relationships. Which the nerves are, some of the nerves are passing below it, some nerves are passing above it. So more important about the piriformis muscle is regarding its location, and especially its close relation with the sciatic nerve. So in people who are long distance runners, like you see people running marathons, or people who do treadmills on an inclination, for example, or doing long distance running, so what happens is that your hip is extended, most of the time. If you are doing long distance running, your hip is extending, and what happens is that there could be swelling of this muscle. And if there is a swelling of this muscle, inflammation of this muscle, that will result in compression of the sciatic nerve. So people with long distance running, they complain of pain which is radiating at the back of their thigh. So that is called piriformis syndrome. And piriformis syndrome usually comes with people who are in, these type of activities, long distance running, you have skiing, like things like that. And these people complain of pain on the posterior aspect of the thigh. Sometimes also what happens is that if you have an injury to the buttock, and there is, because the blood vessels are also coming out above and below the piriformis, and there's bleeding there, that can also lead to piriformis, swelling or inflammation of piriformis and pain over the posterior aspect of the thigh. Yes. How can we we need to give some painkillers which will reduce the inflammation, and as a result, the pain would be reduced. No surgical intervention is required. So you can see the close proximity of the sciatic nerve to the piriformis muscle. It's just passing below the piriformis. You also have a bursa here. You have a trochanteric bursa here, which is separating the gluteus maximus muscle from the greater trochanter. And if you do activities where you are climbing the stairs too much, or you are mountain climbing, you do a lot of mountain climbing, there could be an inflammation of this bursa because you are extending your hip too much, and that inflammation is called trochanteric bursitis. So you have pain over the side of the greater trochanter because you are doing an activity like climbing, or you are running on a treadmill with an inclination, or you are jumping too much, so those activities where gluteus maximus is involved too much, you can have the inflammation of this bursa, which is the trochanteric bursa, which is between the gluteus maximus and the greater trochanter, and you would have pain over the trochanter, greater trochanter of the femur. This is the gluteus maximus, as we said. It's arising from posterior part of the posterior gluteal line. It is also arising from the sacrotuberous ligament, and then it goes and gets attached to the iliotibial tract, most of it, 2/3 of it, and then part of it is going to be attached to the gluteal tuberosity. The nerve supply is the inferior gluteal nerve. We can see the hamstring muscles here. The hamstring muscles include the semimembranosus, the semitendinosus, the adductor magnus, and this is the bicep. Biceps has two heads, the short head and the long head. Short head cannot be taken as a hamstring muscle because it's not coming from the ischial tuberosity. Long head is basically the one which is taken as the hamstring muscle.
Only one head.
Yeah, so the long head of bicep is the hamstring muscle. The short head of bicep is not the hamstring muscle because it does not extend the hip. You need to understand also the function of the gluteus maximus muscle. Gluteus maximus muscle mainly is involved in movements where it's mainly the extensor of the hip, but it acts only in the extreme movements. For example, when you are sitting down and you are standing up, you can feel your gluteus maximus contracting. When you are running, so running, the extension of the hip is done by gluteus maximus. But when you are walking slowly, gluteus maximus is not, it's not basically the muscle which is contracting. In normal walking, the extension of the hip is done by hamstring muscles. But in running or in extremes of positions, when you're standing up, you go climbing the stairs, or you are moving from down up, you are basically using your gluteus maximus. It extends the hip at the extremes of movement. So during running or from standing up from a sitting position, you have your gluteus maximus working. But when you are walking, normally, your gluteus maximus is not contracting. It's the hamstring muscles, the semitendinosus, the semimembranosus, and the biceps, which are the major muscles. That's why, so if you have the injury to the inferior gluteal nerve, you would have the paralysis of gluteus maximus. So you would have difficulty in standing up from a sitting position. But if you are standing up and you want to walk, you can walk. You can walk because your semimembranosus and semitendinosus are there. But if you do not have the sciatic nerve, you cannot stand up. Your standing positions are going to be gone. Okay. Deep fascia we have already talked about before. Let's go to the next slide. Okay. The intramuscular injections in the usually gluteus maximus is a big muscle, so it is a site for giving the intramuscular injections. But you know that the sciatic nerve is passing just below this. So you don't want to put up a needle and injure the sciatic nerves, or you don't want to injure the blood vessels also, because this is the course of the sciatic nerve. So what you do is you divide the buttock or the gluteal region into 4 quadrants, 1, 2, 3, and 4. And this is the outermost quadrant of the gluteal region, which is the safest site for giving an intramuscular injection. You can also do one more thing. You can put your index finger on the anterior superior iliac spine. So if you want to put up a intramuscular injection, you can put your index finger on the anterior superior iliac spine and your middle finger here, and between them you can make a space and you can put up a needle to put up the intramuscular injection. So usually the outermost upper and the outermost quadrant of the gluteal region is the safest place to give intramuscular injections, because you don't want to injure the sciatic nerve. Yes, go ahead. Yeah.
It's a little bit harder to determine or to divide the maximum.
Yeah, so then what you can see, you can put your index finger on the anterior superior iliac spine. Even in the obese patient, you can feel the anterior superior iliac spine. So you put your index finger on the anterior superior iliac spine and your middle finger on the iliac crest, and in between them, the space is the safest area to give the intramuscular injection. Yes, go ahead.
I see some nerves that's giving injection for the high, the quadratus femoris. How does apply?
Yeah, so you can give the intramuscular injection in quadriceps femoris, but the only thing which you need to be careful about is that you don't go medially, because below the quadriceps, on the medial side, there are femoral vessels. So you can give it, the intramuscular injection into the front of the thigh. There are no vessels. You can just put up the needle there and give it into the quadriceps femoris, or you can give it into the deltoid here. So these are the common sites for giving the intramuscular injection. But the commonest among them is the buttock, because gluteus maximus is a very big muscle and there is a lot of distribution. The drug can easily be circulated through this muscle. Okay. I don't know why this is not working. Yes.
So the only superficial muscle is the gluteus maximus.
Yes. So now we are going to look at the muscles. So this is the sacrotuberous ligament, and then you see the sacrospinous ligament, and then we are basically showing you the cut edge of the gluteus maximus. So you can see it is arising behind the posterior gluteal line. It's arising from most of the sacrotuberous ligament, and then it is getting inserted into the gluteal tuberosity of the femur and also the lateral lip of the linea aspera, but 2/3 of it is going to be inserted into the iliotibial tract. The major function of the gluteus maximus muscle is extension of the hip. But extension of the hip, which it does, is at extremes of movement, like from sitting down to standing up position, or you are running, or climbing the stairs. Those are the movements where the gluteus maximus is functional. Okay? The other thing which you need to understand is that there is a bursa between gluteus maximus and the ischial tuberosity. There is a bursa between the gluteus maximus and the greater trochanter. So, we have already talked about the trochanteric bursitis, but there could also be the bursitis of the ischial tuberosity. And that can happen in people who are, chronic, they do bicycling, So if you see people who are sitting on the chair and, doing a long distance bicycling, they usually have pain on the medial side or on the ischial tuberosities. It's because of the bursitis of the ischial tuberosity. Because if you are sitting on the chair and, cycling for a long period of time, you can have pain on the ischial tuberosity, and it's because of the inflammation of the bursa between the gluteus maximus and the ischial tuberosity. Okay. Next muscle which you see here is the gluteus medius muscle. Most of this gluteus medius muscle is under the cover of the gluteus maximus. So if you want to see gluteus medius, you need to cut the gluteus maximus to see it. It lies between the posterior gluteal line and the anterior gluteal line. Okay? And it is inserted on the greater trochanter, on the outer aspect of the greater trochanter of the femur. It is the major abductor of the hip. The gluteus medius is one of the major abductors of the hip. It is supplied by the superior gluteal nerve. Then you have the gluteus minimus, which is completely covered by gluteus maximus. You cannot see it without removing the gluteus maximus. It arises between the anterior and the inferior gluteal line. So it is arising from between the anterior and inferior gluteal line, and it is inserted to the greater trochanter, anterior part of the greater trochanter, and it is supplied by the superior gluteal nerve. Both gluteus medius and minimus are abductors of the hip. And we will tell you what important function they do is that when you are walking, one of your foot is on the ground, and then you raise the other foot and then you move forward. So when the foot which is on the ground, which is the dependent foot, abducts the hip here, which will allow the other hip to get raised up so that you can move the limb forward. Do you understand what I'm saying? Is that the gluteus medius and minimus of the dependent side, where your weight is there, is going to abduct the hip here, and as it is going to abduct the hip, it will raise the hip on the other side. So as it is going to raise the hip on the other side, your leg would become free to move forward. Okay? Then when your foot is down here, now this is the dependent foot, it's going to abduct the hip here, will raise your hip on this side, so this limb will become free and you can move forward. So the abduction of the hip on the dependent feet is the function of the gluteus medius and minimus. If these gluteus medius and minimus get paralyzed, what would happen? You would have abduction. The dependent foot would not be able to abduct the hip. So this on the other side, the free side will not get raised up. So when you are trying to walk, your hip will fall down. So when you start to walk, you have a waddling gait. You're going like this because the hip is falling. So this waddling gait is because of the paralysis of the gluteus medius and minimus. Yes, go ahead. Not necessarily they are walking because of the paralysis or like this because of this. But I'm telling you why waddling gait can happen if you have bilateral paralysis of gluteus medius and minimus. Both the superior gluteal nerves are gone and you have bilateral paralysis. Otherwise you would fall on one side. If it is paralyzed on one side, the other side will fall. But you would not fall on this side because this side is fine. If you have bilateral paralysis, then you are doing this. You're trying to compensate. Your body is trying to compensate the side where the paralysis is. Yes, go ahead.
Can you use a specific term to describe this movement called
It's called waddling gait. Waddling.
What does gait mean?
Gait is your walk, the style of your walk. Okay. Next muscle we are going to talk about is the piriformis, which is arising from the sacrum, the middle three paces of the sacrum, and then it passes through the greater sciatic foramen attached on the medial aspect of the greater trochanter. It is supplied by the piriform nerve to piriformis, which is a branch from the sacral plexus. No major function here. The superior gemellus is a small muscle arising just above the spine of the ischium, and it goes and gets attached to the greater trochanter also. It is a lateral rotator of the hip. Then you have the obturator internus, which is arising from the obturator foramen, and then it comes out through the lesser sciatic foramen, gets attached to the inner aspect of the greater trochanter. It is supplied by the nerve to obturator internus. Below this is the inferior gemellus. So these three muscles together, superior gemellus, the obturator internus and inferior gemellus, they form a tricipital tendon, and all three are small lateral rotators of the hip. They are called lateral rotators of the hip. Inferior gemellus arises below the spine of the ischium and gets inserted on the greater trochanter. Nerve supply is the nerve to quadratus femoris, and then this is the muscle which is arising from the lateral aspect of the ischium and attached to the quadrate tubercle on the crest of the intertrochanteric crest on the posterior aspect of the femur. Again, this is also lateral rotator. So all these three muscles, the superior gemellus, obturator internus, the inferior gemellus and quadratus femoris, they are all lateral rotators, small lateral rotators of the hip. The quadratus femoris is supplied by the nerve to quadratus femoris, which is coming from the sacral plexus. Okay. We have seen these. Next slide. We are just looking at the actions. We have talked about the action of the gluteus medius and minimus. The piriformis muscle is also the lateral rotator of the hip. Superior gemellus is a weak lateral rotator. Obturator internus is also the lateral rotator. And then inferior gemellus is also lateral rotator. And quadratus femoris is also the lateral rotator of the hip. Yes?
What is the obturator externus? The obturator externus.
Externus. You cannot see the obturator externus here. On the gluteal region, you don't see the obturator externus. It is only seen on the adductor compartment. If you take out all the adductors, then you would see the obturator externus. But the only one which you see here is the obturator internus on the gluteal region. Yes?
What movement impacts the tensor fasciae lata?
Tensor fasciae lata muscle? It is basically inserted into the iliotibial tract. So it just stabilizes the knee when you are standing up. Okay? So it's not basically, and you can say that it's partly a medial rotator also, but of the hip, but the major function that it works through the iliotibial tract to stabilize the knee while you are standing up. Yes, go ahead.
Which is the smallest lateral rotation?
Yeah, obturator internus is the most strongest among the all, but all of them are called as a group small lateral rotators of the hip. The other function they have is that because they are covering the the hip joint from the back, so they provide the stability to the hip joint also, because they are small muscles which are covering, like the rotator cuff muscles which are covering the shoulder. They are covering the hip from the back, so they are also providing stability to the hip joint. Yes, go ahead.
The gluteus medius and minimus are stabilizing our leg when we are walking?
No. Gluteus medius and minimus are abductors of the hip. So what happens that while you are walking, the hip where your weight is there, because one of the leg is always up when you are walking. So the dependent hip where your weight is there, the gluteus medius and minimus of that side will contract, will abduct the hip here. As it is going to abduct the hip on this side, it is going to raise the hip on the other side. This allows the leg to become free to walk and go in front. So during walking, you need to raise the hip on the other side. Okay? And that only can happen if you have the abduction action of the gluteus and minimus on the dependent side. Okay. Okay, now we look at the arteries and the nerves. You can see the superior gluteal artery is coming out above the piriformis muscle. It is going to supply the gluteus medius and the minimus muscle. Then you have the inferior gluteal artery and the nerve, which is coming out below the piriformis muscle. It is going to supply the gluteus maximus muscle. Then you can see another artery here, which is the pudendal artery, which is coming out from the greater sciatic foramen and going into the lesser sciatic foramen to supply the perineum and the pelvis. You can also see the inferior rectal and branches which are coming from the pudendal. Now we come to the hamstring muscles. We have talked about the gluteal muscles. We have talked about the gluteal region. We now come to the hamstring muscles. So the hamstring muscles, the first one which you are seeing is the semitendinosus. It comes from the ischial tuberosity, the medial surface, and it goes to the medial surface of the tibia. So we talked about the girl between two soldiers. So sartorius, gracilis, and the third muscle is the semitendinosus, which is attached to the medial surface of the shaft of the tibia. This is the semitendinosus. The next one, it is important in flexing the knee, and it extends the hip joint. So the normal walking, you are basically using your hamstring muscles for extending the hip and flexing the knee. Then you have the second muscle, which is the semimembranosus. It arises from the ischial tuberosity also, goes to the posterior medial aspect of the tibia where it gets inserted. It also gives an insertion. It forms an oblique ligament at the back of the knee joint, which is called the oblique popliteal ligament. And the innervation of both semitendinosus and semimembranosus is the tibial portion of the sciatic nerve. The third of them is the biceps femoris. It has a long head which arises from the ischial tuberosity, and it also has a short head which arises from the lateral lip of the linea aspera. Both these heads are going to come together and get attached to the head of the fibula. The short head is supplied by the common peroneal portion of the sciatic nerve, while the long head of the bicep is supplied by the tibial portion of the sciatic nerve. Again, the function is the same: flexing the knee, extending the hip.
But does every head has a function?
No.
Both of them does it.
Both as a head, as a muscle, are going to do the same. Okay. Next one is the adductor magnus, which is also the part of the so it's also the adductor magnus is also part of the hamstring muscles. We have talked about it in the adductor compartment, so we are not going to go again on the adductor magnus muscle. But the other thing which you need to understand is that you can have if you have movements in sports like, starting without a proper warm up, or you are playing a sport where you have to run at once, you are standing and then you start to run at one go, that can result in avulsion of the hamstring muscles. So hamstring muscles are attached to the ischial tuberosity, and if you have a sudden movement where you are basically running at one go, you can have avulsion of the hamstring muscle, and that can lead to rupture of the one of these hamstring muscles, or pain over the ischial tuberosity. So if you see people who are playing sports like soccer or something, where they are standing and then they suddenly have to run, and in that case they suddenly feel a pain on the back of their thigh, that could be because of the avulsion of the hamstring muscles. Yeah? Keep?
When they try to treat you, they keep hitting this place.
No, if you are basically having the cramps in hamstring muscles, that is a separate thing. But if you have avulsion, or your tendon is ruptured, then heating will not help. Heating will only reduce a little bit of pain. But you need to surgically correct the rupture of the tendon. If it is avulsed, then you have to reattach it to the bone. Otherwise, it's not going to heal. Heating will not help. Heating is only going to reduce the pain. Okay? Okay, we can have 5 minutes break before we start the hip joint.